Good afternoon. Thank you, Twyla, for that introduction. And thank you to the organizers for inviting me to speak today on what I think is a very important topic related to the management of spinal cord injury patients. I have no relevant disclosures to share today, and the objectives of today's talk will be to introduce the different types of pain prevalent in spinal cord injury. I'll review the treatment options for the management of spinal cord injury, really focusing on neuropathic pain. And then I'll discuss some treatment options for spasticity related to spinal cord injury. Just as a background, pain is a significant complication post-spinal cord injury. And as much as we try to manage pain from a non-pharmacological perspective, many of these patients do often require pharmacological management. The prevalence rates of pain in studies have varied widely, anywhere from 25% up to 96% of patients experiencing pain along some course of their recovery in spinal cord injury. Why I think this is a very important topic today is that there's a substantial effect on quality of life for these patients. There's a really high association of pain with depression, anxiety, poor sleep in these patients, which then can further hinder their recovery. This picture here is from a great publication that really talks about the biopsychosocial aspects that really identify the lived experience for our spinal cord injury patients. And I just want to emphasize that pain actually plays a role in the bio component, the psycho component, and the social component. And so it's really, really important that we kind of think about adequately treating pain in these patients. I'm not going to have time today to dive deep into that aspect of the care for these patients, but there's some really great references that are listed if you want to read more about it. The mechanisms underlying spinal cord injury pain remain very poorly understood. So as much as we advanced in the care of spinal cord injury patients, the mechanisms underlying pain, we still have a long way to go to really understand them. And that has really hampered our ability to discover more novel therapies to advance our management of pain. These are some quotes from a really great qualitative study that was done about a year ago in the South African population, where they interviewed 122 patients who were wheelchair-bound, paraplegic patients living in the community with spinal cord injury. And I found this qualitative study very impactful. There was lots of quotes, some of which I included here, that really described the lived experience of these patients very well. The authors of the study came up with 4 kind of overarching themes that they captured in the interview of these patients. The first one being that pain constantly lurks. It's a demanding companion. You try to look outside and the pain says, no, you're paying attention to me. The pain is worse than the direct consequences of spinal cord injury. It affects mood stability, it affects sleep, and some of the other important aspects of care. Pain is restrictive. There's days where the pain can be so bad that these individuals can't work. They can't function on that day-to-day basis. And then finally, life continues despite the pain. There are patients that can learn to control it psychologically and kind of get past it and live with their pain. For many years, there was many different classifications of spinal cord pain that existed in the literature. And it wasn't until several years ago that a group of experts got together and standardized that classification for pain. The goal of the standardization was twofold. One, it was to allow standardization schemes that we can use for research purposes to kind of standardize how we research patients, think about pain in patients. And then the second goal of this classification was to ensure that those folks caring for these patients actually think about each one of these pain types separately. So they separated the classification into different tiers. There's 2 major tiers, nociceptive pain and neuropathic pain. And then they subdivided those different tiers into musculoskeletal pain and visceral pain as components of nociceptive pain. And then neuropathic pain, they interestingly separated into at-level pain and below-level pain for spinal cord injury. The reason why this expert group did that is because we're starting to learn in the literature that there's probably very different mechanisms that underlie these different neuropathic pain types. which would suggest that the treatments that we use for these different pain types might need to differ substantially. For example, one medication that we might use for at-level pain may not work as well for below-level pain. But unfortunately, despite this classification scheme, today, most studies looking at treatments for neuropathic pain still do not separate at-level pain and below-level pain. They're very difficult things to tease out, and it's very difficult to study those things. So thinking about nociceptive pain, when we're thinking about musculoskeletal pain in these patients, it can be located above, at, or below the neurological level of injury, usually in areas with preserved sensation. For musculoskeletal pain, it's usually located in joints and muscles, described as dull or aching, can be aggravated by movement, usually is tender upon palpation, and is often improved with anti-inflammatory medications. Usually in the acute setting, the musculoskeletal pain we see can be due to other injuries the patients may have. In the chronic setting, for a lot of our wheelchair users, it can be due to overuse of those upper extremity muscles or stress on joints. For visceral pain, this is often located in the thorax, the abdomen, or the pelvis. It can be, and it's usually due to some sort of distension or inflammation of underlying structures. So for example, it could be triggered by constipation or urinary tract infection that patients may experience. For our lower level cord injury patients, they usually experience visceral pain that's similar to patients with that do not have spinal cord injury. For our higher cord injury patients, oftentimes these patients have a hard time kind of localizing this sort of pain. They just feel a generalized discomfort that they're not able to localize to any particular area. So it's very, very different. For neuropathic pain, pain caused by lesion or disease of our somatosensory system, when we think of at-level neuropathic pain, this is really pain that occurs at the neurological level of injury or within 3 dermatomes below that level of injury. There's often a peripheral and a central component to at-level pain. The peripheral component being caused by damage to the nerve root, and a central component being caused by damage to the spinal cord itself. With at-level or below-level neuropathic pain, this is defined as pain that occurs 3 dermatomes below the neurological level of injury, but can extend up. It can occur in complete and incomplete spinal cord injury. And we think the mechanisms that underlie below-level pain may involve impairment of sensory tracts and kind of the way that the brain processes sensory input. For treatment of nociceptive pain, I'm not going to focus on this today, but I wanted to at least mention for musculoskeletal pain, really using simple analgesics is effective. Tylenol is first line. Short-term use of NSAIDs, not so much in the acute setting, but in the kind of the rehabilitation kind of chronic phase, usually works well for these patients. And then oftentimes considering opioids as a last line option. Physical approaches for chronic pain are even more important. Patients definitely benefit more from some of these therapies, physiotherapy, hydrotherapy, exercise. In fact, exercise and regular long-term exercise has been associated with improvements in mood and pain in patients. And it's one of the most important things that we can offer these patients. Visceral pain, the mainstay of management is really trying to identify and treat the underlying pathophysiology. It's important to do so because ongoing visceral pain can cause a lot more catastrophic outcomes for our patients, such as autonomic dysreflexia, which we want to definitely try to avoid in this population. For the treatment of neuropathic pain, as many of you know, we use non-conventional treatments to treat neuropathic pain. These often involve anticonvulsants, antidepressants, sometimes different opioids. It's really difficult to control neuropathic pain. The best relief we get sometimes is a 50% reduction in pain. In fact, that's the target that's looked at in a number of studies. And about only a third of patients will actually have adequate relief of their spinal cord injury neuropathic pain. And the available treatments you have, as you'll see in the next few slides, there's really limited evidence of efficacy in spinal cord injury. And so we tend to extrapolate the use of these agents from other guidelines, looking at other types of neuropathic pain. and non-spinal cord injury patients. And unfortunately, even in doing that, the studies we have across the board are very small studies, short duration. Sometimes these agents can require weeks to really show full effect. And oftentimes the studies we have are only a few weeks long. There's very few studies actually comparing one medication to another. And most of the time, the outcomes these studies are looking at they're not looking at functional outcomes or quality of life outcomes, which are really some of the most important things we should be thinking about in terms of studied outcomes in these spinal cord injury patients. In 2010, an interest group from the International Association of the Study of Pain put together guidelines for neuropathic pain and all types of neuropathic pain presentations, not just spinal cord injury. So they were one of the first guideline bodies that actually, or guideline societies that actually developed guidelines for the treatment of neuropathic pain. And in 2015, they updated their guidelines based on this systematic review and meta-analysis that was done, looking at across the board, all randomized double-blind placebo-controlled studies with parallel group or crossover study designs involving many different neuropathic pain types. The bar was set really low here. They included patients in studies with at least 10 patients, very small in. We normally wouldn't do that ever, and at least 3 weeks of treatment, which again is very, very short when we're thinking about efficacy of medications in neuropathic pain. It's important to kind of point out that 50% of the studies included in this meta-analysis and systematic review looked at patients that had diabetic polyneuropathy or post-herpetic neuralgia. So both peripheral neuropathic pain conditions, whereas I just mentioned a few slides ago, a lot of our spinal cord injuries experience central neuropathic pain conditions. So we're trying to extrapolate from this guideline to a group that it may be less applicable. As far as outcomes here for efficacy outcomes, they looked at number needed to treat for a 50% pain reduction as the primary effect measure. Again, not really looking at functional outcomes, not looking at quality of life outcomes. And then from a safety standpoint, they looked at number needed to harm for patients dropping out due to adverse effects. And this is what they found. When looking across different neuropathic pain conditions, there was no evidence of different efficacies for most drugs in distinct neuropathic pain disorders. But as a whole, when they looked at all of these patients with different neuropathic pain conditions, those that had the highest level of evidence were for our SNRIs, duloxetine, venlafaxine, tricyclic antidepressants, and then our cannabinoids, pregabalin or gabapentin. So across the board, these are the most highly recommended based on the quality of evidence, with low number needed to treat, high number needed to harm, and low risk of bias in studies. And I'd say across the board, these are probably some of the most common medications that we'll use for different neuropathic pain types. For second-line drugs, tramadol has some serotonin and norepinephrine reuptake inhibition properties that lend itself to be maybe efficacious in neuropathic pain management. So that's a second-line drug recommendation, and then some topical therapies that can be used for peripheral neuropathic pain localized to a particular site. And then third-line drugs, opioids are in there, mainly because some of the studies looking at opioids primarily included patients with neuropathic pain, although we don't conventionally think of using opioids for neuropathic pain, but they were given a lower line recommendation due to safety as well. This here is just kind of a summary of the doses that were used kind of for these particular studies, looking at those strong recommendations and those weak recommended agents. And you could see here on the right, there's a lot of medications that have been studied that just don't have conclusive recommendations yet. Very small studies, not really widely studied in a randomized fashion yet. So although some of these therapies may be effective, we just don't know at this time how effective they would be. Fortunately, kind of a year after the update to that 2015 guideline, the Canadian Pain Group kind of led the way and were the first group to actually develop guidelines for neuropathic pain specific to the spinal cord injury population. So I wanted to kind of present these guidelines, which were first developed in 2016 and then updated in 2021, and talk about how these guidelines are the same and how they differ from the larger neuropathic pain guidelines. These pain guidelines were really developed to be used in the subacute phase of care to the inpatient rehabilitation phase of care. But we do extrapolate the use of these guidelines to acute care as well, knowing that the onset of neuropathic pain, at least at-level pain, tends to occur in the acute setting, whereas below-level pain tends to onset kind of months to years after spinal cord injury. The Canadian Pain Guideline, they also, in their review, included studies where 50% or more of patients had traumatic or non-traumatic spinal cord injury. So the recommendations here, first line, same thing, cannabinoids should be used. Amitriptyline or TCAs were also considered a first-line agent, but we're given a lower level recommendation than the cannabinoids based on safety concerns. Our TCAs have a lot of anticholinergic side effects, which are not good for our spinal cord injury patients. They can worsen constipation and urinary retention. So though, even though they may be effective, they have more safety concerns with this population. And then in the blue boxes there, they gave equal level recommendations across the board for the things listed in those boxes, but they did feel that it was important to segregate them out based off of evidence for use and into different boxes. I get asked a lot about pregabalin versus gabapentin, which one's better? Pregabalin does have currently, for spinal cord injury specifically, the strongest evidence for any treatment based off of probably better randomized control studies. And gabapentin, also a first-line option. Some patients respond very great to either one. Gabapentin had some studies that showed no difference in terms of outcomes, but and in a meta-analysis that was done, they saw that it did have benefit in spinal cord injury, so it was given a first-line recommendation. Some important differences to pick out between these two. Pregabalin more strongly binds, has higher affinity to the alpha-2 subunit, and because of that, is much more potent. We can get away with using lower doses. Dose it BID, oftentimes based on its half-life, we have to dose it 3 times a day to optimize its kinetics. Because of its stronger binding to the alpha-2 subunit, it causes more calcium blockade, so you can get much more peripheral vasodilation with it, and with that, get much more peripheral edema. So oftentimes, the dose-limiting side effect of pregabalin is peripheral edema in patients. Kinetically, it's a very nice agent. Has very predictable linear kinetics. You double the dose, you double your serum concentrations. It's quite nice. Gabapentin, similar mechanism, although an important difference is that gabapentin has dose-dependent saturable absorption. So as your dose increases, it relies on nutrient transporters across your intestine for absorption. And giving more or presenting more drug to the GI tract doesn't necessarily increase your absorption. And so with increasing your dose, you're not getting a doubling of your dose. It's much less absorption. So that's something important to keep in mind. Sometimes what we'll do in patients is dose it every 6 hours instead of every 8 hours to kind of optimize that absorption in patients, especially in our younger patients with higher GFRs. I'm not going to go through all of this for the sake of time, but I did want to provide, at least for reference, some of the information related to the other higher level recommendations that were given in these guidelines. And then also some of the recommendations that are up and coming that are being studied with regard to botulism, cannabinoids, and some of the opioids. And then there's a lot of things in the pipeline that we're still looking at. If you noticed kind of in the first line recommendations for the Canadian guidelines, what was missing there is venlafaxine and duloxetine. We use them all the time at San Francisco General for spinal cord injury pain. But I can tell you that there's only a few studies looking at these medications in spinal cord injury. And these small studies have actually shown negative outcomes with these agents with regard to pain management, really supporting the evidence that probably the SNRIs have more efficacy in treating peripheral neuropathic pain conditions than central neuropathic pain conditions. But again, we just don't have the evidence yet to kind of support that either way. And then some of these other things listed here, ketamine, lidocaine, have been shown to be effective in the acute phase of care for treating neuropathic pain. But what we've seen in these studies is that as soon as you turn off that medication, the effects dissipate. So really only useful for the time that patients are on it. And the last few minutes, I just wanted to touch on spasticity in spinal cord injury, another very prevalent condition that occurs in these patients with a high prevalence. Definitely more common in patients with higher cord injury or incomplete injury. And usually here we see positive and negative features of upper motor neuron syndrome. You can see some of the positive features listed there. Some of the negative features that these patients experience are muscle weakness and fatigue. Spasticity is important to pay attention to because it's associated with a number of other poor outcomes as it relates to contractures, urinary leakage, falls, sleep in these patients. It can interfere with a patient's balance and mobility and their functional independence and their ADLs. However, not all spasticity needs to be treated. There's potential benefits to spasticity as well, which you can see here. And so really in patients, it's identifying if the negative consequences or effects of spasticity outweigh the positive. And if they do, then we should definitely consider treating it. Another important thing to pay attention to is triggers. If someone has new spasticity, really thinking about some of the acute triggers that can cause that. For example, if somebody has bladder retention or urinary tract infection, treating the underlying cause will actually help to improve spasticity in these patients. So that's important to think about for patients that develop new spasticity. The treatment of spasticity, non-pharmacologic, is always important. If we thought the evidence was bad for medications and neuropathic pain, it's even worse for spasticity. Very small studies, really focusing on use of GABAergic agents, alpha-2 agonists, and peripheral acting agents such as dantrolene, which is something that we don't typically use, which I'll talk about. This here is kind of a list of what those options are. Baclofen we always kind of think of as a first-line agent, but what I'll say is there's only like 3 randomized controlled trials looking at oral baclofen for spasticity and spinal cord injury, which have shown benefit. And there's some studies looking at intrathecal baclofen as well for patients who have, maybe side effects from oral medication. We can use much less drug delivered directly to the intrathecal site in these patients. The side effect of all these medications is sedation, dizziness, definitely something we have to pay attention to. Tizanidine, an alpha-2 agonist, has some trials supporting its use in a randomized fashion, but definitely has some higher dropout rates due to side effects compared to some of these other agents. Clonidine actually has more literature supporting its use in spinal cord injury for spasticity, but we don't often use it because the main side effect of clonidine, hypotension, bradycardia, is not really favorable, especially in our patients with higher cord injuries. Gabapentin, limited evidence showing benefit. Kind of interesting to me, but this really kind of suggests that the underlying mechanisms for spasticity and neuropathic pain might cross over, where some of the medications that we use may be efficacious for both types. Dantrolene, peripheral acting calcium inhibitor, has some efficacy in treating neuropathic pain, but the downside of dantrolene is actually increases muscle weakness. And so we don't really use that as readily for this population. And then diazepam, not much data specifically in the spinal cord injury population, but has been suggested to be used for nocturnal spasm. It's very sedating. And so dosing it at nighttime can really help with kind of the nocturnal spasm that patients may experience. So I have a huge wish list of future directions for spinal cord injury research. I'd like to see more literature exploring kind of the underlying pathophysiology in these patients and the mechanisms behind pain and spasticity, more studies on single agents and combination therapies, and then more studies on some of the non-pharmacological interventions that treat neuropathic pain. So with that, we know that spinal cord injury pain is very challenging to treat. It's complex, has a lot of other behavioral and environmental factors that play a role. And the management should involve a multidisciplinary team approach, thinking about some of these things. And with that, I'll answer any questions.
Questions for Kristin? And I want to apologize. Our break snacks came late. They are at the back of the room now, so help yourself to cookies and fruit. Anything for Kristin?
Hi, Kristin. I'm wondering, what are your thoughts on starting patients on an antidepressant soon when they arrive? What are your thoughts on that?
Yeah, That's a great question. And I think, when I talk about that we use like venlafaxine and duloxetine more readily in the acute care setting based on a lack of evidence, I think we often do that in patients that have anxiety to start, or we anticipate will have kind of ongoing depression or a depressive component later on. So I personally don't have a problem with that. And I think that's kind of why we gravitate toward those agents to take advantage of kind of both aspects of care. There's not a lot of kind of literature specifically looking at treating depression that early in the acute setting. In fact, most of the literature there would say that we shouldn't do that in the acute setting, especially in the ICU setting for depression in general. But I think if we're going to do it using an agent that kind of kills two birds with one stone, is probably okay.
My question is just about, I know when we're in that acute setting, we're, kind of scrambling to treat pain and treat it effectively, and it always seems to take longer than we want. Can you sort of talk about the expectation of duration to onset for some of these neuropathic pain, the, venlafaxine or Cymbalta? And second question, is there anything that you know of that's on the horizon that might be coming that would help or might help?
Yeah, great questions. The onset of effect is a little bit tricky for a lot of these medications. For the SNRIs, which we use, the onset's a little bit quicker. We usually see some relief within 3 to 4 days. Where the onset of some of our other agents, the cannabinoids and whatnot, can be a little bit slower. It's hard to assess, especially in the acute setting, because many of these patients can't communicate with us. We don't really know if they help or not. We're kind of blindly titrating up. But studies would support just overall 3 to 8 weeks, depending on the medication, is what's considered an adequate trial. And so I think we have to keep that in mind. We don't have a lot of literature on combination therapy, but I do think for patients that have severe neuropathic pain, or based on their mechanism are anticipated to have severe neuropathic pain, starting combination therapy early with medications with different mechanisms is often helpful down the line when patients start to get out of that acute phase.